So that's what happens when you grow up in the 80s and you get to pick your theme music. Maybe my hearing's not the best for those decisions, but I think I'm much happier and better for that experience. All right, so we're back, and what do you know? I have my laptop, so that must mean that I've got something to share from Medicrea. All right. So here we go. Now we've got the updated. Laura got back to me, and it looks like, yes, we do indeed have another interbody placed, and there we go. All right, so now I'm looking at this, and my PILL mismatch is 1, and this looks like a surgery that I would do. So I'm happy with this. We're going to revise the previous instrumentation. So this feedback comes, once again, usually it comes when I'm out and about, comes on my phone, I'm able to pull it up on my screen, and if I like it, then I can simply go ahead and approve. I love the fact that the data is here, so you can really drill down into the details. You can customize what parameters that you find important that your engineer will then populate for you. So we've got pre-op, we've got a plan. There's a big green button there to hit approve, so I can just go to my laptop and hit approve. It's going to ask for a little bit more information. It's something we haven't spoken about. So these rods you've got some options with the rods. You have MIS rods, which have an attachment for an MIS holder with a bulleted end at one end, so you get to say where you want the attachment, what side you want bulleted. That's the cranial caudal orientation. You get your rod diameter, you get to pick your material, you get to tell them 2. I've never asked for 20. I think they'd make them for me if my hospital would buy them. I haven't tested that, but you can do, let's say, multiple rod constructs for PSOs or other deformities. And then there's the approve and manufacture, and usually, I have to wait a week, but here we're dealing with a little bit of magic. So Laura, and this is actually Laura, and she deserves a round of applause. I'm reluctant to say this, but usually there's a deadline, and I'm at or slightly beyond the deadline many times when I'm getting these rods. So we've tested FedEx in France, and I would say that they have performed well. But take a look at these. I don't know if we can put them out, or we'll have an opportunity later today to pass it around, but these are the rods. I'm going to bring the patient to these rods, and I'm going to talk about my thought process on how we can do that and do that better, and maybe in a way that you haven't thought about before. They're laser etching marks on the rod for my T10 and my S1 screws. So when I'm placing them, I can line them up perfectly, so I know that where these relations are going to line up appropriately with the spine. And I don't bend them. I haven't bent a rod in years. And so this is something that I actually use as the foundation of my correction. And that, I think, is just spectacular. So take a look at them. I think it's worthwhile to see. So my talk is about integrating enabling technology with data and AI. And I think the data and AI lives in everything that we've spoken about before, how you understand the compensation that may occur in different parts of the spine, and it's built into this, and this is what's going to come into the operating room with me. But there's another piece of it, because I don't think these pieces, whether it was Medicrea before it was brought into Medtronic, or Mazor, or navigation, or Flora, or whatever you use, they don't work well in isolation. They do certain things, but they can't do others. And so the idea of integrating these systems, I think, is incredibly powerful. So we've seen slides similar to this before. This is my attempt to use shadows and arrows when I figure out PowerPoint. But basically, it's a learning ecosystem, right? And we started with the surgical planning, and the AI is built in there. And then the very next step is precision, and that's part of this learning ecosystem. What I'm going to say something here is that this measuring is not new. We've been trying to do this for a while. Take two-dimensional x-rays, come up with a plan, go to the operating room, and then get nothing that looks like the plan. That's the problem. And even now, I would argue that it's a little bit of a challenge, as beautiful as these rods are and the plans are. If you can't make that next step to actually hit your number and do what you plan to do, it's a broken system. You can't get out of first gear. You can't go very far with it. And my struggles were starting to realize in my short construct cases, my focal deformity cases, other people call them degen, is that if I actually came up with a number, and there's still some debate about what that number should be, Well, I had a number in my head. How do I get there? And so I go to the operating room, and I would try the interbodies, and I'd try rods and try other things, and I just couldn't get a precise type of result. Sometimes I get it, sometimes I wouldn't. And sometimes you just, if cages come in 6-degree increments, it was Goldilocks, I needed something in between. And then it was almost 4 years ago now that I had the opportunity to get a Mazor robot. I went and I saw Kees Polstra, and he was explaining I was trying to learn from him. He'd done something like 800 cases at the time, and he's just really facile with it. And we were doing a T10 to the sacrum perk. And I had tried that once, and I thought he was nuts, because that case took 12 hours, and I swore I'd never try one again. There are all these different problems that occur with how do you line up the screws, and how, the rod bend, and how do you do all this. And he was looking at me, he's like, Greg, it's the robot. Just plan the screws in a straight line, and you pass the rod. And I said, well, what about the bend? He's like, well, just don't put the L5 screws in so deep, so your rod doesn't have to be so flat. And he just went on with his day, and the case turned out, and my head exploded. I'm like, wait a second. You get to control your construct. You can design a construct, and I don't have to just hub the screws down against the spine, and I don't have to fan them out like a Christmas tree to follow the anatomy. I can look for opportunities in the anatomy to build something a little bit more elegant. So what is robotics? I do not think that robotics is at all related to navigation. Navigation, you think about the pedicle, you go find the pedicle, and you get down it, and it shows you where you are. Robotics is a planning platform. It is a three-dimensional planning platform, which is why I really like it, because everything we've talked about today has been based off of two-dimensional x-rays, but already built into enabling tech and is this ability to actually look at the spine in 3 dimensions. This looks like something that would weld cars at a Toyota plant. That really all that is it's the assist. It's helping you achieve that plan. And I'll show you a little bit. But you go into the software, you plan what you want, and then the robot arm actually just helps you take you to that spot. And navigation, now that it lives on this platform, is a verification so you can see that you're achieving the plan. So this is a screenshot from Mazor. I sped it up, so if you've had a lot of coffee, this will seem like normal speed. But what I'm showing here is, yes, you move the screws around, and you make it so you're safe and in the pedicle, and that's how we think about nav. But what I really want to show is the fact that once you start building this construct, you can start understanding the relationships. So you can see how, as I move the screws, that the skin incisions were changing, and I could see the relationships between the rods. So you start to understand with robotics at a very granular level what's happening at the pedicle, but at a global level what's happening to the rest of the spine. So all of a sudden, you start thinking, well, if I can control these things, can I do a more elegant surgery? And initially I was doing more MIS because I could line up my incisions. My operating room loved it because I had, much fewer trays. I mean, now my surgeries are done. We know our rods, we know all our screws, we know our implants. We open up something that looks like a shoebox as opposed to trays and trays of screws. But can it actually help you do better surgery? Everyone else has made this point for me before. I know that Chris has shown us that we can't just focus on alignment and think we're going to solve all of spine. And maybe good alignment, it doesn't guarantee you a good outcome. There's much more to it. But I will also say there's plenty of evidence to say if you give someone bad alignment, you're very much on a track towards a bad outcome. So alignment does still matter. So patients returning to the operating room with higher frequency, this is the disaster case that I can show. They're everywhere out there. I can also say I didn't start this, this surgery. It started with a very flat fusion at L4, 5, L5, S1. Someone tried to extend it up with a T-lift. I tried to, this was at a time when I was thinking, well, we do ACRs above, but if there's no substitute, you can't put lordosis somewhere else. You've got to put the lordosis where it needs to be. And sure enough, she wasn't distributed well. She fractured above, and she's extended to her neck. This is not a good story. We need to try to avoid it. And also the understanding is not just PILL, distribution matters. You can fuse someone flat 4-to-1, PILL may still be pretty good, but you're going to create problems somewhere else. Distribution matters on survivorship. So if we want to get really granular, I mean, maybe patient-reported outcomes have too much variability in them, but it's very finite if someone comes back to the operating room. And so we can look at survivability, and alignment does seem to impact that. And there's just more and more data that's trying to help us understand the importance of distal lordosis between L4 and S1. So if controlling alignment, especially in these short constructs, 1 and 2 level fusions, especially L4 to S1 is important, how do our rods work? And I want to just share my thoughts on this. One, you have rod contour. And that's simply if you have 3 points of fixation, if the rod is bent, how much does it push that middle point forward, and then does it fish mouth open? And contour is important because if you put a flat rod in, you're going to suck that middle vertebrae back, and you are going to flatten them out. But just simply pushing on the middle vertebrae isn't a precise way of controlling alignment. So contour is an important concept. And that's how we really achieve things right now. With polyaxial pedicle screws, which are a vast majority of what people are using, we count entirely on contour. But also think about this. There's no effect of rod shape if you only have 2 points of fixation and polyaxial screws, because there's no ability for that contouring effect if you don't have a middle segment. So these polyaxial screws and well-contoured rods, they work better on the long segments, but the shorter the segment it gets, the less of the effect. So there's also this idea of angular control. And so I was chipping away at this from a robotic standpoint, and someone said, yeah, there's this guy out in Colorado who's using monoaxial screws. You got to meet him. And so I love it because like everyone's been working on the same problems, and then like we meet, it's like, where have you been my whole life? Like, and it is like you were my hero. So I was really smiling with that one. So yes, so there's this idea of angular control. Okay, have you ever tried to put in a bunch of monoaxial screws? They are incredibly unforgiving. Incredibly unforgiving. They have to be put in the exact spot at the right angle, and if you don't do that, then things don't lock down. It doesn't work. But you can do that with a robot. So we started getting the idea, could you just take monoaxial screws and just by controlling depth and angles, put them into L4 and L5. So this is a slipped L4-5 that's flattened out a little bit. That's what I'm trying to show there. And just by locking it down to a straight section of rod, simultaneously reduce the spondylolisthesis and get the desired angular control. Because that's really hard to do with any other technology. But you can see, you can plan this out. So much like how we'd use Caspar pins in a cervical spine, you converge them and distract, you can open it up. We were putting the screws in at angles and then locking them down to a straight rod to open the spine to a very precise lordosis. And we are controlling for the depths of the screws and trying to model something like this. And you can see like, all right, I'm going to need to pick a different interbody there. Every time I get in front of Medtronic, I petition for monoaxial screws with towers, so I don't have to try to do this just through little incisions. So, okay, I've done that again. But here we are. So we made little stab incisions, MIS place screws, struggle a little bit with trying to get them locked off without towers, but you can do it. And just to show you that, obviously I'm learning on how to size and cut the rods initially. This is the only time I've tried to line up 6 screws, but it works. But here we are, and I just wanted to show that when we looked at this data, just to a proof of concept, we were able to get everyone within 2 degrees of the desired lordosis, which is well within my error of measurement. So as far as I can tell, I'm accurately restoring segmental lordosis. I don't know how to do that any better with fluoro or other techniques that don't allow me to plan this all out ahead of time. Problem was we were finding that we were limited to converge the screws with a straight rod. I could do that for one level, but let's say if I needed the 36 degrees L4 to S1, I can't converge them 36 degrees. So now we need to have rods that are bent. And once again, in comes Metacrea. They're happy to make me a rod. I like a 6.0 rod because I'm leaning on that rod for my control. And now we can start planning these out. And we can hit our target. So my goal L4 to S1 here was 44 based on the work that we did back and forth to try to do our best understanding of how to model this patient's spine, and we hit it. And so I think that's spectacular. I think that's different. I think that's a new way of thinking about your constructs and using your posterior constructs to tightly control alignment. I've had 2 cases recently where there was one case where we went in and I did A lifts, and the spine just fish mouth open. It was 2-level A lifts, and I wanted 36 degrees, and I was somewhere around like 44, 45, which in my mind is starting to push too much. We went in the back, had the rods, monoaxial screws, and it brought it right down to 36. So too much, took it to where I wanted. Very next case, undershot by 7 degrees for a very similar procedure, locked in the rods, took it right to the number. The idea is that, yes, I need the spine to follow, and rods are important and contours important, but it's just building precise constructs and having this tool, we can complete the loop. Because now if someone says, Greg, I want you to get 44 degrees at that segment, I know how to get 44. I'm not talking about 50 or 36 or some range in there. I know how to get 44 because I now have the bridge between what exists in the digital world to actually what happens in the operating room. And that is what robotics is right now. And so I've always said that the rods need screws because how these function is very dependent on a consistent understanding of how you're placing your tulips. So if you're a little too deep here or a little too proud here, that's changing the contour, and that's creating a fair amount of I guess, variability or background noise in your rod precision. If you perfectly contour your screws like you can with robotics, then you take away that noise and you get a more precise result. So this is a patient, so a deformity patient, and I guess you probably alluded to, now I like doing these perk and I like showing the x-rays. So this is a patient with, you can see both a sagittal and coronal deformity. And so what does it look like to plant it now? So this is a slide or a video that picks up once all the screws have been placed, but I haven't done any contouring of them. So I'm in the Mazor software. Well, that kind of looks like a mess. But now I straighten out the spine to the correction I think I'm going to want to get. And then there are tools that exist within the software to help me understand screw cadence. So now I'm working towards the spine and the shape I want to be, and I'm building the structural relationship of the rods to meet the spine. So there are 3 things that need to happen. I need to shape the spine the way I want to be. I need to have the rod shape what I want it to be, and then I control the precise relationship between those two with the screws. And here, even now, for it to be an MIS case, I can't have the towers cross. It's like Ghostbusters, don't cross the streams. You don't want to bounce one tower off the other under the skin. So I'm even fanning the screws out so I can create a very elegant construct where I can see all the skin incisions. My screws aren't going across. You can see how the rods would be uncorrected, but you can see how there's going to be a corrective maneuver there if I pass straight rods that are appropriately contoured. So this is what this patient's screw plan looked like in the corresponding rod plan. And you can see the amount of data that I like. So they really will work with you. This is why Laura needed applause. So look at the right-hand column. Like, I want to know angular measurements of every end plate to end plate. So as I'm doing the inner bodies, I can track my progress. The red numbers in the middle are actually the delta, so I can see, well, how much of a change do I need to have? And so that's very helpful for me to understand if an A-lift's appropriate, a T-lift, or whatever approach I'm going to have. All this is known ahead of time. My stress level running into this case is next to 0. Everything's figured out ahead of time. We do these cases perk, but I count on anterior inner bodies L2 to S1. And then this is what it looks like. The robot's been detached. All the towers are sticking out through the skin. We've actually flattened out the rod contour. So the rod contour is flatter than the spine contour, and that distance is just managed by the screws. So you can see the rod is less lordosis than the spine. And so here we are. I know where the big corrective points are, but the patient, all this correction occurs just by controlling the relationship between the rod and the screws. That's why I like sharing these cases, because that's a different thought process than what exists out there now. This is my foundation. Maybe it's the foundation to a cathedral. Hopefully this one's flying buttresses will last. but everything is built off by controlling the relationships off of here. And it's not always the same depth. The amount of planning and control that you can have is really spectacular. All right, and so then you can look and see how the numbers turn out. And, I would say that there are times where I could get closer to my goals if I did open, but we can see with rigid spines that quite often I'm usually about 7 or 8 degrees of rod bend, so then we just build that into the model. So let's say I have a patient who I want to do an age-adjusted deformity correction. What I may do is actually plan them much closer to perfect alignment, understanding from my previous cases how much drift or rod bend I see when I do them perk. So we actually have close to 30 now, so I need to update these numbers. But about a year ago when I had 20, I wanted to go back and look and actually see if I was actually helping patients with this. Because there's nothing like looking at your long-term outcomes to really humble you. So we had 19 patients at the time, and what we were seeing is that these cases did take a while, but I wouldn't stage them, so 6 or 7 hours. The mean blood loss was 356, but I'll tell you, if I don't do laminectomies, our mean blood loss is under 200 cc's for T9 to the sacrum or T10 to the sacrum. Most are in the hospital, just 4 days. Most went home. None went to an ICU. I don't have an ICU in the hospital where I have the robot. 97% of the screws are placed. Sometimes when I get in there with small pedicles, I just choose to leave a couple out because I didn't feel like that was something I wanted to instrument. All the rods were placed successfully, cranial to caudal. We've had, in this series, 1 case of PJK. Subsequently, I've had another, so just full disclosure, but it has substantially reduced my PJK rate. We had 1 iliac vein laceration that was just approach related. With OLIFs, we see some transient thigh pain, but they all resolve. And we can see that there's a significant ability to correct spinal alignment just by planning the posterior construct and delivering it precisely. So when we talk about this learning ecosystem, we can get out of first gear. So we can not only go from surgical planning, but you actually can achieve what you plan. And that's why I think these technologies have to exist under the roof of one organization, because it's the software, right? You could see that. What the software does and how you visualize is immensely important. And I actually think, not to try to sell robots, but that's the real distinguisher. The robots look the same. It's a mechanical arm that moves and you operate through it. But it's what the software allows you to do that's absolutely what distinguishes them. So software has to integrate with the hardware, meaning it has to know what the screws are and what the rods are. The rods have to integrate. It all has to be under one umbrella for someone to actually be able to achieve what is possible with these technologies. And so that's why I'm pretty excited that it's all here now and we're talking about it. And if you're going to bring data and AI to the operating room, which is ones and zeros, you need to have that digital bridge, that robotic bridge or enabling tech bridge to actually get it there with the precision that we need. And so now we can have this learning system where our planning is not just a mental exercise, but is actually achieved. You can analyze it, you can refine and do better, and then you can go ahead, capture that data, model again, and do better for the next patient. And that's what I have. So thank you very much.